friends. First of all, I want to thank Dr. Gamal Agmi and the organizing committee for inviting me to this Congress. My topic is global impact of COVID-19 on respiratory diseases. But before going on to the impact of COVID-19 in respiratory diseases, I want to mention a little bit on the pathogenesis of this disease. The early stage where we have the alveolitis with type 2 pneumocytes involved, with surfactant layer involved. Then we have the severe stage where we have the cytokine storm with activated neutrophils, fibrin deposition, cellular debris, slowing damaged bronchial epithelium, widening of edematous interstitium, and beside the alveoli, the microvascular involvement where we have microthrombi, thrombocytes, neutrophils involved in the small vessels. Then we have the third stage where we have the wound repair. The cytokine storm may be still continuing, but the major factor is fibrin deposition, whether we can have fibrinolysis or fibrotic lung. So this is the recovery phase, but it may result in fibrosis. It is not only involving the lungs, respiratory system, but also other organs in the whole body. So it's a systemic disease. It can involve sort of the central nervous system, kidneys, heart, liver, even pancreas, and besides them, eyes, nose, and oral part of the body. So the systemic involvement in this disease also affects and has impact on the respiratory system. So we should see the whole disease as a whole and see the impact in this context. First of all, I want to start with the general global effect of COVID-19 on different diseases, and then we'll pass on the impact of this disease on respiratory diseases. These graphs are from South Africa. In this graph here, you see the prevalence of comorbidities in COVID-19 patients. As you see, hypertension, HIV, diabetes, active TB, and cancer are the most prevalent diseases seen as comorbidities. Fatality proportion of hospital admissions increase as the comorbidity number increases. It is only 5% with no comorbidity, whereas it is about 25% when there are 2 or more comorbidities. Here in this graph, we see many different diseases in patients with COVID-19 disease. So it shows the fatality rates when a patient with COVID-19 has different comorbidities. The highest fatality rate is in the comorbidity, which is chronic renal disease, malignancy, chronic cardiac disease, diabetes mellitus, hypertension, HIV, chronic pulmonary disease, active TB, or previous TB. As you can see, chronic pulmonary disease and asthma have a fatality rate of about 18% compared to chronic renal disease, which has 44% fatality rate, compared to malignancy, which has 34% fatality rate, and chronic cardiac disease, 30% fatality rate. Even when compared with diabetes mellitus, which has a fatality rate of 25%, chronic respiratory diseases have lower fatality rates. And I want to emphasize one thing more. Diabetes is a very important disease in COVID-19 pandemic. Why? Because even a diabetic patient has well-controlled diabetes, the fatality rate is about 5 times higher when this patient is infected with COVID-19. If diabetes is uncontrolled, then it is like 14 times higher in fatality. So we should be very well aware of the prognostic effect of diabetes in a patient with COVID-19. This graph is from CDC. It is to emphasize that when the comorbidity number increases, regardless of age, hospitalization and fatality rate increases. But this graph shows one thing more. But it is in older age matters. After the age of 60, you see these green bars. They show that even a patient in the older ages does not have any comorbidity, only age by itself increases the hospitalization and fatality rate. In children, the rates of comorbidity and fatality rates are lower. A Chinese study on 1,590 COVID patients showed ICU admission, invasive mechanical ventilation need, and death are more likely with hypertension, diabetes, malignancy, COPD, cardiovascular disease, cerebrovascular disease, chronic kidney disease. So comorbidities are important and they cause more death, more ICU admission. They are bad prognostic factors. Let's see the respiratory diseases. Lung cancer and COVID-19 being together in a patient. What happens? Respiratory complications increase in rate and severity compared to general population and other cancers. Why? Because it's due to worse baseline lung function owing to smoking, lung cancer-related changes. Pneumonia, pneumonitis is seen in 80% and ARDS in 27% of these cases. The severity, ICU admission, and invasive mechanical ventilation need and mortality are significantly increased in lung cancer patients infected with COVID-19. As you can see, the rate of severity is 20 to 71%. ICU admission, invasive mechanical ventilation need is between 21 to 33%. Significantly increased mortality ranges between 18% to 55% compared to other cancers. However, I want to emphasize that there are potential compounding factors for the increased mortality risks in patients with lung cancer and COVID-19. What are they? Smoking history, increased age, advanced age, comorbidities, specific cancer treatment, and these factors are shown in Tarawal's study. So there are larger prospective studies required to show these factors and their relation to stages, genetic and histologic profiles in lung cancer. The meta-analysis by Prevalence and colleagues showed that significantly increased mortality is very profound in lung cancer patients compared to all other cancers. Here in this graph, you see it's significantly increased in lung cancer. In lung cancer patients, there's another challenge, clinical radiologic overlapping. And this is a real challenge for early COVID and lung cancer diagnosis. We have to differentiate COVID-19 and treatment-related pneumonitis. Pneumonitis due to radiation or immune checkpoint inhibitors. Why? Because the treatment varies and level of observation is different. It is suggested that COVID-19 tests should be done for all suspected lung cancer patients, regardless of treatment-related pneumonitis possibility. There are two patients here from my own experience where there was a delay in diagnosing COVID-19 due to overlapping clinical radiologic features. This patient is a patient infected with COVID-19 during the diagnostic process for suspected lung cancer. The real lung cancer area is this part, right, upper lung area. There was adenoid squamous cancer in this right upper lobe. But during the diagnostic workup of this patient for lung cancer, he was infected with COVID-19. And these infiltrations in the middle and lower lung zone bilaterally are due to COVID-19. However, the PCR test, 4 PCR tests were all negative after this chest X-ray. And he ended up in ICU. He was a stage 4 lung cancer patient and he passed away. but there was a delay in diagnosing COVID-19 due to overlapping clinical radiologic features. This is another case, a lung cancer patient suspected of having COVID-19 pneumonia after radiotherapy, but confirmed to have bilateral radiation pneumonitis. As you can see, you cannot differentiate the radiologic pattern, the interstitial or ground glass pattern of radiation pneumonitis from COVID-19 lesions. So, how to continue lung cancer treatment is a real challenge after diagnosis of COVID-19 in a lung cancer patient. However, I can say that there are variations in outcomes regardless of holding or continuing lung cancer treatment. Increased risk of adverse outcomes based on the type of treatment are controversial. Whether chemotherapy or immune checkpoint inhibitor treatment increases the risk for adverse outcomes is just controversial. There is no evidence-based data on this issue. More studies are needed. Lung cancer treatment should be not delayed in mild to moderate COVID-19, and it should be restarted as soon as safely possible in severe COVID-19 cases. I just want to touch a little bit on the interventional procedures and bronchoscopy in lung cancer patients during COVID-19 pandemic. We have to classify the indications for interventional procedures as emergent cases, urgent cases, and elective cases. Emergent cases should be done immediately without losing time. And these are symptomatic central airway obstruction, symptomatic moderate severe airway stenosis, massive hemoptysis, and stent migration. The cases that can be a little bit delayed for a few days, several days, are pulmonary mass suspicious for malignancy, the mediastinal hilar lymphadenopathy suspicious for malignancy, foreign body aspiration, suspicion of pulmonary infection in immunocompromised patient, total lung lavage, or mild to moderate hemoptysis can be done urgently, but we can give several days or a week to do the procedures. All other indications are elective and can be delayed for several weeks. So we have to do this classification during pandemic. As conclusion for lung cancer and COVID-19, for managing implications and impact, we can say we have to implement multidisciplinary and individualized management. This is necessary. Management of challenging ethical scenarios can be done by using patient-centered practical approach and coming to rational decisions by emergency and priority of the case. Rational use of telemedicine should be used to decrease COVID-19 risk and workload. We should continue clinical research despite all challenges due to pandemic, and we should also promote psychological and physical health of healthcare workers to increase the success in diagnosis and treatment. When it comes to TB and COVID-19 being together in a patient, what are the potential impacts of COVID-19 on TB care cascade? There is very little evidence to quantify the impact of COVID-19 on TB burden. However, Mycobacterium tuberculosis infection, TB disease burden, accessed TB tests, notified and treated cases, and treatment success are suspected to be affected significantly by COVID-19. There are studies going on, but currently we don't have all the data about these impacts, how they are impacted by COVID-19. And it can change according to the setting and time. Even within a country, it can be different in different areas. There are some data, small data, showing that there was 20 to 30% decrease in TB notifications during pandemic from United States, Africa, Central Asia, and Europe. Is this decrease in incidence of TB or decrease in access to TB diagnostic services? Most probably, there were decreases in access to TB diagnostic services, but it has to be shown. There were decreases in testing of TB in South Africa, but in several months, it resulted in the increase of the percent of positive tests for TB. There were 45% fewer tested for MDR-TB, and what is the result? Undiagnosed large number of tuberculosis cases, late diagnosis and treatment, and at the end we have poor outcome. There were limited treatment support and medication backups, and as a result, treatment interruption, delay, decrease in treatment adherence, worsening TB treatment outcomes. The first meta-analysis from China showed that TB prevalence in COVID-19 is up to 5%, not so high. However, in severe COVID cases, the prevalence of TB may be increased up to 1.5%. 49 patient cohort from many European countries and Singapore showed that tuberculosis is diagnosed before COVID-19 in half of the cases, and most of the cases with TB and COVID being together in a patient were active tuberculosis. In 85% of the cases, TB was active in COVID patients. Role of COVID-19 in active tuberculosis development and role of TB sequela in COVID-19 evolution have to be shown in further studies because there is no evidence-based data on these topics. The first meta-analysis I just mentioned from China showed that the risk of TB death is higher with COVID-19, 1.5 times higher. A study on 69 patients from 8 countries showed that overall fatality in cases with COVID-19 and tuberculosis is about 12%, but it may change between 5% to 14%. Mortality was more likely in elderly, in severe and or resistant tuberculosis cases. A study from South Africa, a country where there is high prevalence of tuberculosis, HIV, TB co-infection, TB, whether drug susceptible or drug resistant, and previous TB have been shown to increase the death risk when the patient is infected with COVID-19. And this death risk was between 1.5 to 3 times higher. There is a global study on TB and COVID-19 named Global TB Network and World Health Organization study with 36 countries and regions involved, and which started in 2020 in October. Will show, it's still going on, will show the characteristics of these cases, global repository for concomitant COVID-19 and TB, and clinical outcomes. This graph is from that South African study I have just mentioned. It shows that when there is active TB, previous TB, or HIV, it increases the fatality rate in all COVID patients and also in hospitalized COVID patients. So we have to be careful with TB and HIV infection when there is COVID-19 infection. So we have the priority gaps for understanding and mitigating the impact of COVID-19 on TB. What are they? Which gaps? And they should be taken as priorities in studies. Delays to diagnosis and treatment, changes to patient costs, impact of COVID-19 infection and disease on TB progression and mortality, impact of changing contacts, mobility on transmission and settings. Let's see what happens when COPD and COVID-19 are together in a patient. The prevalence of COPD in COVID-19 patients is not so high. It's about 5% in average, but may go up to 16%. Males, advanced age, dyspnea, hypoxemia, pneumonia are more commonly seen in COPD patients. Mortality rate is about 13%, not so high in COPD cases, and there is no significant difference in in-hospital mortality risk. Overall survival rates in COPD cases do not show statistical difference when compared to non-COPD groups. During the pandemic, some studies showed that mean COPD admissions and mean COPD exacerbations decreased significantly. ICU admissions were not changed. Oral corticosteroids were used less before the recovery study, and inpatient mortality showed no difference. But patients had some subjective complaints regarding their disease control, and they had negative impact on their mental health. Let's look at asthma and COVID-19. There is low prevalence of COVID-19 in all asthmatics. It's less than 1%, and in severe asthmatics, it only reaches 1.6%. Asthma in hospitalized COVID-19 is in higher incidence. It's like 16.5 to 25.8%. But when you look at all COVID-19 patients, asthma prevalence is only 10-11%. During the pandemic, asthma exacerbations were not very high, even decreased, but it was only a little bit increased in middle-aged asthmatics. Most asthma patients did not complain much. They were compliant with their treatment and could access their asthma treatment. What was the health problem for asthma patients? It was not asthma-related complications or asthma-related problems. Most of the health problems in asthmatics were due to diabetes-related or cardiovascular issues in about 41% of the cases. So, according to several studies and meta-analyses, we can say that hospitalization risk and more severe COVID-19 risks were not increased in asthmatics during pandemic. Why asthma patients did well during the pandemic, although we expected them to do worse? There are some hypotheses, although they are not evidence-based. The decreased prevalence of COVID-19 in asthmatics was related to T2 inflammation, eosinophilic inflammation in some asthmatics, the decreased ACE2 SARS-CoV-2 TMPRSS2 receptors in asthmatics, and also the use of inhaled corticosteroids and their effect on the ACE2, SARS-2 and TMPRSS2 receptors, because these receptors decrease with the use of inhaled corticosteroids. But these are just assumptions or hypotheses. If they have to be shown in studies, these three factors may have an effect. There's another study showing that allergic T2 phenotype asthmatics had decreased hospitalization risk compared to non-allergic ones. And without considering any asthmatics, in COVID-19 patients who had lower eosinophil counts, the COVID-19 severity was higher. So there is a relationship with eosinophil level, low eosinophil level, and poor prognosis or severity of COVID-19. And another idea or hypothesis is that COVID-19 infection decreases blood eosinophils, and in eosinophilic asthma, eosinophils are increased. So during pandemic, eosinophilic asthmatics did well because if they are infected with COVID-19, their eosinophil levels were not high. But these are all assumptions. Asthma patients, when they had COVID-19, they recovered well, and their recovery rate was similar to non-asthmatics. Let's look at interstitial lung disease infected with COVID-19. What happens? First of all, when these two diseases are together in one patient, there is a clinical radiologic differentiation problem, and this causes diagnostic challenge. In interstitial lung disease, mortality rate is increased to 33 to 49%, and these patients are hospitalized more frequently, 74% hospitalization rate, ICU care, 47%, and discharging is much more difficult. Most of the patients with interstitial lung disease and COVID-19 cannot be discharged from the hospital. Their disease is severe, mortality rate is higher. The treatment effects of corticosteroids and antifibrotics remain to be seen, but if these patients are having invasive mechanical ventilation, mortality rate is very high. Pulmonary hypertension and COVID-19. COVID-19 in pulmonary hypertension is not high, 2.1 in 1,000, similar to general population. COVID-related mortality in pulmonary hypertension patients, it's only 12%, hospitalization 33%. To decrease exposure risk and transmission, the units that were taking care of pulmonary hypertension patients had visits scheduled, telemedicine, which increased from 10% to 97% during pandemic. Some procedures were decreased, such as echocardiograms, pulmonary function tests, 6-minute walk tests, and some procedures were increased, such as perfusion scans without ventilation scan, CT angiography for chronic thromboembolic pulmonary hypertension, and there was stratification for need of right heart catheterization. Obstructive sleep apnea in COVID-19, and the risk of COVID-19 infection and risk for hospitalization is increased in these patients to a certain extent. Not so high, but there are some compounding factors. And what are they? The increased ACE2 receptor, increased body mass index, which is the prevalence of obesity is high in obstructive sleep apnea patients, diabetes, and male gender. So these compounding factors may be affecting the risk of infection and risk of hospitalization. So there are studies needed to see whether obstructive sleep apnea is an independent risk factor for severe COVID-19 and also an independent risk factor for COVID-19 mortality. These two issues have to be seen with further studies. What happens when a patient has COVID-19 and pulmonary thromboembolism? Pulmonary thromboembolism at admission of COVID-19 patient is about 14%. However, if pulmonary thromboembolism in COVID-19 patient occurs in intensive care unit, the percentage is 20 to 33%. In normal pulmonary wards, the rate is lower, up to 9%. And there is no difference in thoracic CT staging in pulmonary thromboembolism positive and negative patients, meaning the severity of the disease is not related to the presence of pulmonary thromboembolism or not. Death due to pulmonary thromboembolism occurs in 7% of COVID-19 patients, and overall pulmonary thromboembolism mortality within the cases having COVID-19 and pulmonary thromboembolism is about 27%. And I want to emphasize on these CT scan images one thing. The infiltrations we see in a COVID-19 patients here are not only due to pneumonitis or alveolitis or pulmonary lesions, but they can be also due to infarcts, ischemia, due to pulmonary thromboembolism. This is shown in a study, in a recent study. For example, in this one, this area is due to pulmonary thromboembolism and occurring infarct. So we have to be kind of thinking about both issues, pulmonary lesions and lesions due to infarcts are also pulmonary lesions. I am meaning the alveolar involvement and vascular involvement. They can be both together. Pulmonary thromboembolism in COVID-19, why does it occur? First of all, the patient may have underlying risk factors for venous thromboembolism. Another issue is the cytokine storm, inflammatory response, endothelial dysfunction, and the results of this affect hemostatic system and abnormalities occur. And hypoxia due to pneumonitis plus microvascular thrombosis in lungs contribute to the hemostatic abnormalities, and we have microvascular pulmonary microthrombi, intravascular coagulopathy, decreasing platelets. In the end, we have pulmonary thromboembolism. Hospital admissions for respiratory diseases during COVID-19 pandemic, how did they go? When we look at hospital admissions, they decreased for respiratory infections and chronic lung diseases, as you can see in the upper part of this graph. But in the lower part, you see for diabetic ketoacidosis, intracranial hemorrhage, myocardial infarct, and cancer, there was no change in admission rates. They were the same, similar to the admission rates before the pandemic. Why is it so? It's because of, change in health-seeking behavior, but also decrease in respiratory infections. During this period, some respiratory infections may have decreased because of limitations in mobility, staying at home, but also many patients could not go to the hospitals because of getting scared to get the infection from hospital area. So these two factors affected respiratory infections and chronic lung disease admissions, hospital admissions decreased. A meta-analysis by Aviard and colleagues showed that risk of severe COVID-19 in asthma did not increase, and in fact 2.3% in severe COVID-19 patients were asthmatics. For COPD and chronic respiratory disease, the risk is increased 50%, but when we look at the overall picture, 55.2 or 8.6% in severe COVID patients were made up of chronic respiratory disease. If we look at the situation from a bird's eye, it is seen that the relative severity risk for asthma and COPD and chronic respiratory disease is much lower than that in male gender and diabetes mellitus, and the risk of death for both diseases is much lower than that due to any disease, due to any cause. So risk of mortality is not significantly increased in chronic respiratory diseases during COVID-19 pandemic. It's only 12% for chronic respiratory disease and 6% for asthma, compared to very high mortality risk and hospitalization for chronic heart disease, increased body mass index over 23 to 40 kilograms per meter squared, male gender, chronic neurological disease, chronic kidney disease, and cancer. However, again, there are some significant interactions between age and chronic neurologic disease, age and diabetes, age and body mass index. Although diabetes is not a respiratory disease, I want to touch on this disease because this disease significantly affects COVID-19. Diabetes in COVID-19 patients, the prevalence is about 10%, but may go up to 19%. Mortality and severity is doubled if the fasting glucose is above 126 and random glucose is above 180. And corticosteroids increase hyperglycemia, and there is a debate going on whether the diabetes patients benefit from corticosteroids regarding mortality, invasive mechanical ventilation, and oxygen use. This figure, I just want to summarize what happens when we have hyperglycemia in COVID-19 patients. COVID-19 infection causes dysregulation of glucose metabolism. This causes increased glucose and glucotoxicity. In the end, we have interstitial lung damage. If this is very severe, acute respiratory distress syndrome results. Dysregulation of glucose metabolism also causes endothelial damage, increased thromboembolic risk, pulmonary thromboembolism, deep venous thromboembolism, and in the end, mortality increase. And the aggravation of inflammation by COVID-19 infection causes immune modulation, and this results in multi-organ dysfunction. So the results are acute respiratory distress syndrome, deep venous thrombosis, and multi-organ dysfunction. So the regulation of glucose in blood is very, very important in COVID-19 patient and its prognosis. Post-acute COVID-19 syndrome, it's after the first month of the infection. It is going from first month to sixth month. It can be very long. And there are sequelae, one or more sequelae in 14% of the patients under age 65. Risk for sequelae increases by increasing age, comorbidities, and hospitalization. But again, I should emphasize some patients under age 50, no comorbidity, not hospitalized, may have risks for some sequelae. Here in this figure, it's a very nice figure to show what happens after the first month of COVID-19 infection, post-acute COVID-19 syndrome. The patient may have constitutional symptoms like fatigue, muscular weakness, joint pain, decline in quality of life, but also pulmonary complications, dyspnea, cough, persistent oxygen requirement, central nervous system sequelae, cardiac, vascular, urologic or kidney problems, and hair loss. And these may be very varying in different patients, and also the time course or the duration of these sequelae may change. I'm approaching the end of my talk. Multidisciplinary outpatient care for COVID-19 patients is significant, very important. Pulmonary and cardiovascular medicine, hematology, neuropsychiatry, urology, physical treatment, primary care should all be involved in the outpatient care for COVID-19 cases to get the best result from the treatment. Also, COVID-19 patients require, especially the patients who had moderate to severe COVID-19, may require rehabilitation. This rehabilitation should start early, even during the hospitalization time, when the patient is capable of doing some small motions activities. So early mobilization, early verticalization, multisensorial approach, tracheotomy, weaning and lung rehabilitation, cognitive rehabilitation, neurological involvement should all be considered. And again, pulmonary medicine, neurology, physical treatment, cardiovascular medicine, and all other required branches should be involved in rehabilitation so that we get the best outcome from the treatment. Thank you for your attention.